Hi everyone, welcome to researchamp.com. Thank you for watching. I'm really very excited today to teach you all about AMIODARONE-induced thyroid disorders, okay? Again, I'm just introduce myself. My name is Dr. Pramil Cheriyath. I'm a physician working in the United States, program director, internal medicine residency program, and a transitional residency, and associate program, associate professor of medicine, 2 large medical schools. And now I finished my introduction. Let's start our topic today. Okay, the topic is again amiodarone-induced thyroid disorders. Like yesterday when we gave the presentation, we talked about amiodarone-induced thyrotoxicosis. Okay, today we're going to concentrate on the amiodarone-induced hypothyroidism a little bit. Okay, now before we go anything, first we need to know the structure of amiodarone and what is the similarity with the T4, T3, and reverse T3. All right, let's go back and look at the biochemistry, like what happens over here, okay? So we're going to revisit what T4 is. First of all, you got tyrosine residues, okay? And then look at the iodine. I'm going to count. 1, 2, 3, 4. There's 4 iodine molecules attached to tyrosine residues, and that is called a tetraiodothyronine, okay? That is what a 2 iodine molecule. Now let's look at T3. Again, tyrosine residues. Let's count the iodine. How many? 1, 2, 3. Okay? And where is this? Iodine attached. This is in the outer ring. Okay? So you got 3 iodine attached. So this is called triiodothyronine. Okay? Triiodothyronine. Okay, T3. Now let's look at, we have to one more we need to understand. That is reverse T3. What is it? Again, you got tyrosine residues. Let's start counting. We got 1, 2, 3. Okay? Now, that is 3, right? So that is actually the reverse T3. Why do we call reverse T3? Because iodine is attached to the inner ring of tyrosine residues. Okay? So this is called reverse triiodothyronine. Okay, everybody got it. Now we understood T4, T3, and reverse T3. Let's look at amiodarone. Amiodarone, what is that? Benzofuran derivatives over here, and it attached 2 iodine molecules right there. Okay, so again, 2 iodine molecule. They got 3 molecules of iodine, 3 here. But when it comes to amiodarone, you got 2 iodine molecules, my friend. Okay. Now, what does that tell us? It's again, amiodarone contains a lot of iodine. Lots and lots of iodine. That is almost like 40% iodine in a drug, in amiodarone. Let's say if you got 200 milligram tablet and you're taking maybe like 3 times a day, that equivalent, each tablet contain like 75 milligram of iodine, right? That can cause like a lot of problems. Okay, we'll come back to that. Now let's look at the prevalence of amiodarone-induced thyrotoxicosis. Amiodarone-induced hypothyroidism. Okay, you got 26% subclinical hypothyroidism. Nothing happened. You just got some lab abnormalities, but 5% become overt hypothyroidism. Good. Full-blown hypothyroidism in those people. Now let's look at the pathophysiology. What does amiodarone does? We already said, look at the amiodarone. What do we have? 2 atoms of iodine attached right there, right? And 40% contain iodine. That's like a lot of iodine coming here. What does it do? Amiodarone, what happens is like it got like some other effects over here also. Type 1, and they inhibit type 1 and type 2 deiodinase, which convert T4 to T3. Okay, so T4 goes up, T3 will be less. Before we talk about this, I think we need to talk about this effect called Wolff-Chaikoff effect. Okay, it is like Wolff. Remember that Wolff-Chaikoff effect. You have to know what is that. It's called an escape phenomenon. Let's say if I give you like a lot of iodine, what happens is like thyroid kind of shuts itself off to protect it and keep the balance. But the Wolff works only for 2 weeks. After 2 weeks, he's going to quit and go to Alaska. So you're going to be in big trouble right there. Okay. Now, what does it do? Amiodarone block the T4 to T3 by inhibiting type 1 and type 2 deiodinase. Okay. And then it blocked the T4 entry into the cell. Now, this is happening in the liver, and this is actually happening in the anterior pituitary over here, okay? And then you also got an effect on the heart. because of the direct T3 antagonism, because there's a metabolic product of amiodarone, kind of the amiodarone, that's one kind of affecting on the heart and causing like a lot of arrhythmia and all that. Okay, so just summarize one more time. You got Wolff-Chaikoff effect. Thyroid function, thyroid just kind of shut off because of a large number of, iodine entering, and then that's only for 2 weeks, it quit. And then, also you have like T4 conversion to T3 is blocked by inhibiting type 1 and type 2 deiodinase, okay? Type 1 and type 2 5-deiodinase. In the liver, they block again. They inhibit type 1 and type 2 5-deiodinase, block the conversion from T4 to T3, and then you block the T4 entry into the cell. Now, let's look at what happens into the euthyroid, like what happened when you start giving a euthyroid patient amiodarone and duration of the treatment, what happened. Let's go look at the course of what happens in the after somebody taking amiodarone, right? If it is less than 3 months, you got T4 and free T4 increased. After 3 months, not so much, but like 40% still have like increased free T4. T3 and free T3 decreased, right? Because we know this is kind of blocked right there, okay? So there's going to be decrease. And then reverse T3 can increase up to 20 in less than 3 months, but then it can more normalize after 3 months. Then TSH, what happened? TSH goes up, increases. What happened? The reason for that, right? You need like T3 to inhibit the production of TSH. That's the normal mechanism. If you don't have, so you're going to have less T3. So it's not much inhibition of the TSH, so they will go up to 20. That's like a very important topic, okay? And total thyroid binding globulin is going to be normal in both situations. Now, let's look at some of the differentiating features between amiodarone-induced hypothyroidism and amiodarone-induced thyrotoxicosis. Good to know. Okay, comparison like what happens. So what happened in the amiodarone-induced hypothyroidism? There's a persistent block in the intrathyroidal iodine organification. But if you look at it, and the amiodarone-induced thyrotoxicosis, you got type 1 and type 2. Actually, in the type 1, iodine-induced, there's like an increased hormone synthesis. Okay, in type 2, there is destructive thyroiditis. That you have to know the differentiation. So there's high dietary intake in iodine and thyroid autoimmunity. Over here, you got pre-existing thyroid disease, maybe latent Graves' disease. And then early onset, uncommon after first 18 months. Okay, so amiodarone-induced hypothyroidism is uncommon after 18 months. But when you talk about amiodarone-induced thyrotoxicosis, it's unpredictable. And then you can even have that after you decide to stop the amiodarone, you can still have it. Okay, and then look at that. TSH is going to be extremely high, greater than 20 over here, because we talked about you're going to be less T3 because of the blockage. So less inhibition, there's going to be more TSH. Here, TSH is low or undetectable. And then T4 is going to be low. In this, T4 is going to be high. Okay, and the treatment, you amiodarone withdrawal, or you can thyroxine substitution you can do. Here, treatment is kind of different. You got type 1, you just go thiamide and then potassium perchlorate, and then type 2, you give steroids. Now, let's look at our treatment. How do we treat amiodarone-induced hypothyroidism? Okay, first, you start giving the patient come in, has a cardiac problem, you start like 100, 200 millions of amiodarone. What is the first thing you have to do? First thing, you need to get the baseline thyroid function studies to make sure there's no underlying diseases going on. So very important, you get the free T4, TSH, and all of the thyroid antibodies, you check it. Okay, and then after you wait 3 months, and then you repeat the whole thing again. Now, if everything got a normal, if it is stable, you can just continue the amiodarone, and then what happens is like after amiodarone continued every 3 months, or every few months, maybe you can check the thyroid function tested again. Let's say after 3 months you checked your thyroid function. There is some thyroid abnormalities we talked about. There is thyroid-induced, amiodarone-induced hypothyroidism. Okay, based on the lab values we talk about. TSH is high, T4 is low. What's the next step? Next step is you need to find out there is chronic autoimmune thyroiditis. If there is chronic autoimmune thyroiditis, you will give levothyroxine replacement and it's done. Okay? Let's say if you have a normal thyroid gland, what do you have to do? You have to ask a question. Can I stop amiodarone? Right? A lot of times you cannot stop. It's a wonderful cardiac drug, right? You need to continue. So if you said, I mean, if a cardiologist said like, hey, we need to continue, yes, what's our next stop? I mean, cardiologist said no, continue. You cannot like stop amiodarone. You give the patient levothyroxine. Let's say cardiologist said like, forget it. We can find another drug. So what do? You stop amiodarone and reassess after 2 months. If it is euthyroid, you continue every few months. You check the thyroid function test. Let's say, unfortunately, this happens only in 50% of the people. The other people, they can go into permanent hypothyroidism, and you know what to do when permanent hypothyroidism. What do? You give thyroid replacement. Okay, levothyroxine you give. That's in a nutshell. Now let's take a step back and look at our beautiful whiteboard right here and go over like some of the main things. Remember, amiodarone, 2 atoms of iodine attached, pretty much similar to T4 and T3 and all of that kind of thing. So that's what the effect is. 39% or 37.5% exactly iodine in the drug. Okay, so if you have like, let's say 200 milligram, 75% is like iodine. Just remember that. And then 5% can go into overt hypothyroidism. Okay, then look at the pathophysiology one more time. You look at the Wolff's takeoff effect. That's only 2 weeks. And to protect the thyroid is Chekhov off phenomena or escape phenomena. To protect it, thyroid turned off so the body can balance it out, the thyroid function. After 2 weeks, Wolff, get out of there. It's gone. You can't find it. And then also like the other problem is like T4 to T3 conversion. You need type 1 and type 2 5-deiodinase, amiodarone inhibited. Not only in the anterior pituitary, it also watch out in the liver, my friend. It happens in the liver. And it blocked the T4 entry into the cell. And of course, you remember like what happened on the heart. It got heart because of the T3, direct to T3 antagonism. Also, amiodarone got the end metabolite. It's called desethyl amiodarone. Okay, that's what affect the heart. The heart problem happens. And then remember, like, I mean, look at the difference between the main differences between amiodarone-induced hypothyroidism and amiodarone-induced thyrotoxicosis. It's kind of good to know. I'm just going to look at the TSH is going to be extremely high here, and TSH is low and detectable. T4 is low and T4 high. And the treatment, look at the treatment, is very different. The treatment, amiodarone withdrawal or thyroxine substitution up here, and the other one, type 1, you got thionamide. And what else? You can give potassium perchlorate, okay? Type 2, you give steroid. That's like a big thing in the treatment section. If you check the IL-6 in this people, IL-6 is going to be extremely high. Now, how do you treat it, okay? First, we have to go back. You start the patient, cardiologist said, like, we want to give amiodarone. First thing you have to do, call them into the office and check the labs. You check the T4, free T4, you check the TSH, you check the free T3, and you also check the thyroid antibodies, okay? That's what you need to make sure. What are you doing? You're making sure there is no baseline problems of thyroid function before. And then after that, you do another 3 months, you check the labs. And let's say if you find abnormalities we talked about right here, TSH high and T4 is low, then you know this patient have like what? Amiodarone-induced hypothyroidism, okay? So if it is a chronic autoimmune thyroiditis, levothyroxine replacement. If it is a normal thyroid gland, you have to ask the question to cardiology or yourself, can we stop the amiodarone? If we can stop it, and then you can just reassess in 2 months, 50% become euthyroid, and then you can just follow up. Let's say cardiologist said, no, we have to continue, and then you have to give the levothyroxine replacement. Great topic, my friend. Thank you so much for watching. Study hard. We'll be back with another presentation.